beyond the direct contract, connecting the community. Our speakers at the front of the room. Doug Hetherington is the CEO, founder, and program architect at Health to Business. He is joined by his business partner, Garrett Weldon, VP Provider Partnerships and Clinical Strategy, also at Health to Business. Please give it up for Health to Business.
Thank you. Great to be here with all of you. I'm a 20-year broker for the most part up until recently, and most of you, a lot of people here, yesterday I had an opportunity to actually meet face-to-face for the first time. As a broker, you tend to be somewhat landlocked in where you operate, and now I'm a vendor. We even have a booth out in the hallway and everything, right? We're official. And so today is a little bit of maybe about kind of what was that journey like? How did I go from being a consultant, trying to impact change in my community to where we are today? And I love the theme of the You-Powered Conference. And it's about you. And so this is a little bit exciting for us to get to have an opportunity to present what our experience has been like, what many of you have been experiencing, and why this is so hard. I'm supposed to have a clicker here. There's always the important part of the why, right? We each have our own personal reason. This is a picture of my family from about 5 years ago. We were fortunate enough, I think this was Playa del Carmen. My family's kind of on the right side, my parents in the middle, and then my sister and her family off to the left. And really, this was my original why. If you go back probably about 2007, 2008, many of you will remember a recession that we went through. I was brave and had decided to kind of walk away from the corporate agency side and go start my own consulting firm. Really out of frustration, but blind frustration. And I got hit hard. And I can remember sitting in my kitchen, looking at my young children at the time, and I probably had the worst feeling I had ever had in my life. I've always had this dream about retiring by about the age of 55, and in that moment I realized that there was no way that dream was ever going to come true, as long as I was in this industry anyway. And part of the reason for that was the cost of healthcare. I kind of understood the economic side of it and how quickly it was going up, and the realization to me was I wasn't sure how I was going to afford it in later age, let alone how my children were going to be able to afford it, and there was no way that my grandchildren were going to be able to afford it. I'm now 6 months into being a grandfather. I may not look that old, I'm not, right? I have younger kids, but they decided to get a start early, which is awesome. Being a grandparent is extremely exciting, but at the same time, it's a little bit scary because it's not the same as when I was her age. The cost of health care and what it really means to us. So that's my original why. So this kind of set me on this journey of saying, I'm not going to accept this any longer. So I need to go figure out what I can do to solve the problem. So this is a little bit of reflections of what that journey looked like from that moment forward. That's when it began for me. Most of you probably don't know who this is. And if you do, then you're probably a bit of a health policy nerd like I am. I love to follow the political side of this. I think it's just absolutely fascinating what we have not accomplished in healthcare from a policy standpoint and the whys behind it. And Michael Levitt was one of the people that helped me understand that. It was September of 2009. I was in Sun Valley, Idaho at a large healthcare conference, a leadership conference, in a room very much like this with about 350 people very much like this. These were great health leaders of organizations, different vendors, very similar to this. As you can see, Michael Levitt, as you look at his little bit of a resume, he was originally the CEO of Levitt Group. At the time, I worked for Levitt Group. He had moved on by then. He had actually achieved the governorship in the state of Utah. Ultimately then, when I met him, he had just left HHS. He was the secretary of HHS under George W. Bush. And at that time, if you remember, we had a health reform discussion going on. The Obama administration had come in and really was running on this platform of health reform, which made a lot of sense when you said it out loud, but those of us in the industry, as we were starting to kind of understand it, realized that it probably wasn't going to work all that well. At this time, he had founded Levitt Partners, and he was the keynote speaker. And he gave a presentation that I will never forget to this day, and I'm going to share the story that he shared with us, because I think it helps us understand why healthcare is so messed up. He threw out a scenario to everybody in the room. Imagine yourself, right? We all work hard, we have a lot of stress, things going on, and sometimes we have days where we're a little more tired than others. But what if by day, you're thinking, man, I cannot get my energy back? So we decide to go to the physician. Physician runs tests, they're inconclusive. Now you go in to get some more tests, more conclusive. You have cancer. You're given 8, maybe 12 months to live. Now, you have a choice. If you treat it aggressively, you might buy yourself another 18 months to live. Now, this was 2009. Fast forward to today. His number was about $350,000 as a cost. I could easily say that's probably closer to $600,000 or $700,000 now, if not more. I had a family at the time, 3 young children, and he asked, would you pay? And in the entire room, there were maybe 3 or 4 hands that went up. Because most of us recognize we can't do that to our families, right? But we knew that was the cost. And as I looked around the room, I was kind of surprised by that. It helped me think, man, I'm really rational. I'm approaching this with just common sense, that I wouldn't want to do that to my family. And then he said, what if it was your spouse, your child? Would you pay? Every hand in the room went up. That's the problem with healthcare. It's not healthcare, it's not sick care. I always say there's a difference between health insurance and health care. But at the end of the day, it's our problem. We mandate healthcare. It's a social mandate. It's not a God-given right. It's not a government right. It is a social mandate that we mandate everybody has the right to high-quality, effective health care because it's too painful to think about what it would be like if we didn't have it. At that time, I had a grandmother that was about 16 months into cancer treatment. She was at the end stages. Her scenario had been almost identical to this. And I can remember going to see her in the assisted living, where there was my grandfather with dementia, right? And she was scared to death as to what was going to happen. But all of a sudden in this moment when she realized she was almost at the end, it became slightly rational for her. And I shared this story with her. I was moved by it and I said, when you were diagnosed that day and you were sitting in the room with Dad and Grandpa, why did you decide to go through all of this? She said, I didn't. They did. She never got a choice. Think about that. There's a lot of parts in healthcare that are just like that. You don't get a choice. It is a social mandate. So I share that all with you because at that moment I recognized it was on me. That her time was gone, but I was a professional in the industry. I was frustrated with what was going on and I wasn't willing to accept it any longer. And hopefully after today, all of you walk away with the same idea that we all together have to come together and work with one another. It's not this solution or that one, it's all of them coming together to reinvent healthcare for all of us. I went on an interesting journey. I pointed fingers for a while, began to look at the pie of dollars within healthcare. And it was very clear to me that one of the big areas, and I really appreciate the prescription side of this, because there's a lot of just, that's a whole racket, right? But I was really looking at the medical bucket, coming from small town Idaho, right? 50, 60, even 70% of the dollars of claims were going to, as I call it, facilities or buildings and machines. It had nothing to do with healthcare, right? This was health technology or a big brick and mortar building in, downtown in your city. And so I got into the reference-based pricing and I got very aggressive. Then I had the idea, I met Gary Becker that year, in fact, of starting a captive where everybody had to do reference-based pricing. Great idea. And so I started marketing this around my community. and I ran into a healthcare CFO of a hospital, 40 years in the industry, small town community, small hospital. And as he walked into my event, he came up to me and introduced himself and said, "I'm here to see what you're about to do to me." And I didn't like that. I did not like that. That wasn't what I wanted to do. I didn't want to go mess up his community because I recognized they needed him. He was the only hospital there. Whether his prices were right or not, we still need health care. So we sat down and we learned from one another. I shared what our clients' experiences were like. So I say the tail wagging the dog. And you know what he shared? His experience was almost exactly the same. And in that moment was when I then came to the realization that health products and health networks were both abdicating back to an investment company at the end of the day that's motivated by shareholders, right? Shared this last night. I think 25 years ago, there were no insurance companies in the top 50 of the Fortune 500. Fast forward to today, you've got 2 in the top 5. And they are by far the fastest growing. So that's where the dollars are going. That's where the bulk of the dollars are really going. So he helped me understand that he was part of the solution and we had to work together. So we built community plans for that community, and then the next community up the road, we began to collaborate. Businesses started coming into it. And we had some fantastic successes because we were all willing to sit at the table. I remember sitting in a room with one of the clients that we had convinced to do this. And at the time, they had a $4,000 individual deductible, $8,000 family deductible. And we're going through the presentation and the benefits, and we had the zero deductible health plan, and it was pretty much copay based. And we got to the section on maternity, and all of a sudden there was a little bit of noise coming from the back of the room. So I stopped the presentation right there, and I said, "Hey, there must be a question, can I help?" There were 2 ladies sitting in the back. One of them was clearly pregnant. The other one was her coworker and her friend. She kind of spoke on her behalf and said, "So if we're understanding this correctly, today she's scheduled to go to hospital over here, and that's going to be $4,000 for her and $4,000 for the baby? If she chooses to go there, yes, that's correct. But if she chooses to go to this hospital, the one that our business is now partnering with, it's $400 for her and $400 for the baby?" And I said, "Well, that's close. It's only $400 for her. We don't charge the kid for showing up." I share that with you because we can think differently. That didn't make sense to me, right? I had been in that situation of having a child on an HSA, and I got to pay this giant bill. We got penalized because we grew our family. Think about this. Employers out there have young people that have just jumped onto their plans and they want to start a family. And bankruptcy is driven primarily by health care, and we find out that 70% of the time those people have health insurance. We have no protection. There is no insurance component to this, right? So at some point we have to recognize that yes, we can solve problems, and we can have the child without saddling these people with all of this debt. We can. I then had another very interesting experience. About this time when we were having some great success with some of these programs in that section of the state, I was dealing with my own healthcare issue. I played college basketball, shocker, continued to play a lot in my adult years, and ultimately paid the price with a knee that was giving me a lot of troubles. And we were almost certain it was a torn ACL. So in preparation for what I figured was going to be a surgery, I had a client that was a large physical therapy firm. I was meeting with them around their renewal, and it was a good one, so they were smiling. And of course, when they heard I had a knee problem, they're like, "Well, now we're going to figure out how to get something back out of him." So they referred me to their young new physician out of the University of Utah that they said, "He's a knee specialist. He's also an uber athlete. You guys are going to get along great. This will be perfect." So I showed up at the admissions desk with my HSA, walked in and said, "You might as well treat me like I'm cash pay." I kind of got this strange look from the lady because she's looking at my insurance card, but I really knew what it meant. We all know what that really means. I was planning, I'm going to go through this. And then I walked back and I was introduced to the physician. And I explained to him how I got there. And it was really interesting because he kind of looked at me and he said, "A broker? What the heck is a broker? Can you explain this to me?" And as I began to describe what our interactions are, as I've learned to call it spreadshitting, right? Go to the front page with your 35% renewal, show everybody what the options are. You get them to the end of the page because you've already know which carrier they're probably moving to. Then you flip the page and then you start pushing out on the plan design, trying to get this thing back down to 10 or 15 so that they'll at least sign. I watched him visibly get upset. And I realized in that moment that clinicians were different. This wasn't financially motivation for them. They were truly here to help people, but that we were getting in the way. Not most of us in this room, but many of our peers, as we would call them, right? Another recognition that we had to think differently. Now, I was very fortunate because as our conversations continued and he began to learn what I was doing, he also began to learn how messed up it was. That most of us learned that when you step into unbundling, it's chaos. It is really challenging. And so for the last 3 years since we started Health to Business, I have thanked Garrett and the rest of my team on a daily basis, and I say thank you for helping me to clean up my mess, and thank you for caring for your community. So I invite Garrett to come up to the stage, and he is going to give you probably one of the best educations on what that chaos looked like over the last several years.
So I am a clinician, like Doug said, and I absolutely loved it. I loved, that means I really liked it, being on the front line with patients. And when I started learning what Doug was doing with these unbundled self-funded plans and direct contracts and cost containment and bringing employers into a fiduciary standpoint with their health plan, it like captured me in a way. Sometimes we think we have ideas, but frequently ideas just like, they capture us, they take us. And it took me because it aligns so deeply with what I was trying to do as a clinician. I was asking my patients to take responsibility, perform this exercise, perform this movement, engage, take responsibility, and I was trying to contain cost. I didn't call it that. I was trying to keep people away from MRIs that were inappropriate, keep people away from surgeries that were inappropriate, keep people away from inappropriate utilization. And I'm like, wait a second, I'm doing what you're doing. Responsibility, cost containment. Because if you track back, one of my favorite courses in PT school, we actually had like 3 different brokers come in. One was a fully insured broker, talked about what they do. One was kind of an ASO broker, talked about what they do. Another one was like this unbundled, witty, cutting-edge specialist, talked about reference-based pricing, captives, PBMs, pass-through, all this stuff. And then we had all these different vendors come in, and it was a fantastic course. No, that was just a joke. I didn't get any of that. 0. No brokers, no PBMs, no vendors, no stop-loss carriers, 0. I had 0 education on how my services were being represented in the marketplace and how they were being financed. 0. But when push came to shove, responsibility and cost containment, I understood that. So I left clinical practice, and for the past years now, I've been all across the country talking to the provider community, administrative community, hospital CEOs, regional CEOs, chief strategy officers, actuaries, the data analysts who actually do the work, thanks data analysts, right? Orthopedic surgeons, anesthesiologists, family med. I've been sitting with the provider community, teaching them that they can actually engage down to the employer level. That if the employer will take responsibility, they can once again take responsibility for their constituents via direct contracts. And when you look at direct contracts, you can actually start making some differences because of the flexibility that Doug alluded to. There's flexibility, there's transparency, you can make differences. But I need to level set. I need to set some definitions. So we're all talking about the same thing. When I'm speaking of a direct contract in this industry, we often say, oh, the BUCAs, they're not the payer. They're the carrier. The employer's the payer. Okay, principle number 1. If you're doing a direct contract and the employer is not assuming via a joinder or via how the contract is written, the role of the payer, you're not doing a direct contract. You're creating another network. Hats off to you. We've tried that. Principle number 2. I'm not referring to bundled payments. Often a bundled service is where you go, you sit with a hospital, you sit with orthopedic, you sit with some provider entity and you say, okay, yeah, let's do a knee, let's do a hip, let's do a maternity package, right? A bundle. Direct contracts, in my world and the way I think of them, are global services. Every single DRG that hospital offers, every single CPT code, every single offering that clinical practice renders needs to be represented in the direct contract. It's a global direct contract so that it can ultimately be the anchor by which you replace your network. That's the goal. As I move through those, I want to speak about truth. So frequently right now in our day and age, we think the number of likes or the number of tweets equals the truth of a given statement. No. One of my founding beliefs is in the replicability of the idea. Because it rings so true as a clinician, right? If a new guidance or a new practice comes out, especially is going to change the way we work with patients, there better be another study coming out showing the same results. It better be replicable. It's one of the first questions I ask. And I'm not talking about like Ford Pinto replicability, like good, something that's sustainable, something that's actually meaningful, that does good for the community. That type of replicability. And when you get to the direct contract space, we need to look through it in that lens. Are these replicable? Because if not, you're just creating something that is not going to change your community. It's not going to get the provider community on board. In fact, the provider community on board. How many providers are in this room right now? How many licensed providers? Not enough. Thank you all for being here. I myself am one as well. Not enough. If you think that you can't change you can change your communities without the service you're ultimately representing down at the table with you. So when it comes to direct contracts, there's 4 types. And we need to go through them because they all have different impacts on the number of people that you can replicate it with or if they can scale. And so that's why it's kind of shaped as a pyramid, is to represent, right, the number of lives that can actually be served via these types of direct contracts. Type number 1, closed. This is when one employer works with a provider and only that employer can access the contract. It's really where a lot of the direct contracting space started. The direct contracting space has really only been around, at least in print. Kaiser Family Foundation reported on it for the first time in 2019. 2019, that's it. Then it was a way that employers were accessing healthcare. And so it's very fragmented. There's not a lot of maintenance in it. It's kind of this Wild West arena. And a closed direct contract only allows one employer. I don't even care if you're an enterprise employer. You can't impact the community if it's a closed direct contract. Type number 2 is what we call open with constraints. This starts to allow more than one employer to join in to the given contract, but it often has constraints, plan design constraints, geography constraints, size of employer constraints, what carrier they're coming from constraints, that ultimately make it something that can't be replicated and actually impact an entire community. They've got to be between 50 and 100. That's who can join. Oh, right? Constraints. The third is what we call open. And I love this because you have to do this with the provider community, not to. Let me say that again. You do direct contracting with the provider community, not to them. An open direct contract at a philosophical level starts saying, as a provider, wow, I actually understand a little bit about unbundled self-funding, and I should be doing everything I can to help my community get there, because in getting there, it makes it sustainable for my community and for me. So I want as many employers as possible to be able to join this. I don't care if they're 2 lives, I don't care if they're 20,000 lives, I don't care if it's 150 lives. Make it open. It's not controlled by one person. It's a community asset. Open. In some of our most innovative and cutting-edge direct contracts, and this goes into the 4th, there's really 2 rate sheets within the same direct contract. Rate sheet number 1 is open. Anybody can join. Rate sheet number 2 is what we call a full pay. It's starting to contemplate what it would be like to actually remove the providers from the collection business and to make the engagement with the member so meaningful that they actually enjoyed the healthcare experience. It's a full pay model. It's where you really get down to margin-based contracts, fully, because the dollar's so dang efficient. And so as a community, as an industry, we need to recognize that we are on the cutting edge, and what has been fragmented, what has been kind of almost a control play, an exclusivity play, if we're actually going to change what we're doing, change how we've been engaging, we have to start working towards open direct contracts. And then again, in the most cutting edge ones where providers really get it, a secondary rate sheet in there that is a full pay rate sheet. Those are the types of direct contracts. Are providers willing to have their services represented via a direct contract out in the market? Yes. I said I've been across the country talking with different providers, different administration levels. Are they willing to do this? We've been part of now over 52 hospitals, helping them understand hospitals. And I'm not saying like, we've got to understand the inpatient experience. You have to work with them. You're going to have to sit at the table with your local hospitals. And this gives an avenue to start working with you. Hospitals, providers, yes, they're willing to represent this. And what excites us most is that now other brokers, other communities are starting to build on our platform so that their communities can also have their direct contracts administered, can have them open, can have them available to all sizes of employers. So it's becoming a movement. It's becoming people working together, and we're just giving them a platform to build so that it can not just impact your book of business, but it can impact your entire community. So when we get into that level of thinking, I want to share with you a few lessons learned. Doug alluded to one at the beginning. He said, what in the heck is a broker? So when I first started my clinical practice, I actually was trying to work with the employer community. I went out, I made relationships, I engaged with them in many ways. And I started building my book of business around some of these employers, which was awesome. And then the broker showed up and changed their carrier to one that I was out of network with. And now those same patients had a $50,000 out-of-pocket maximum because I wouldn't pay the $1,000 fee on a monthly basis to be part of said network. And when I was talking with the employer, I said, again, I was still in my learning phase. We didn't have this in school. I said, what? Like, does a broker, is that like a title of their work, or is that like the outcome of their work? Because it seems that every time you talk with them, you end up broker. Like, who is this character? And they're like, I think it's both. I'm like, that's not good. That's not good. So I want to share with you some lessons learned from the direct contracting space. I want to go through a few different lenses, provider, employer, so that we can deliver better experience to the member. Prior to do that, the space has become a little wild. It's like, you get a direct contract, and you get one too, sir. And it's all freaking over the place. And if you're like me, which we all are, you flip through all the pages, find the rate sheet, and you're like, oh yeah, I want this one. And everything you just flipped through, those are called terms. And that's the actual responsibility of the direct contract that someone has to assume. I know we all want the rights of the direct contract, but the terms matter. And so I just want to hit upon 4 terms that actually matter. The first is who you're contracting with. This goes back, I've hit it again, I want to hit it again because it's so key. We believe, moving forward, direct contracts need to be 3 parties. The provider, the direct contract administration firm that's taking responsibility, the responsibility of the terms, and the employer as payer. You got to know who you're contracting with. Okay? These are direct contracts. If not, you're just creating new networks, a new TPA network, a new broker network. Awesome. Term clauses, termination clauses. This is most important for your inpatient hospitals that have impacted the underwriting of the plan. Okay, that have impacted the underwriting. If, heaven forbid, this came and it was termed in the middle of a plan year, your employer and all those members are in a really sticky situation. So we need to make sure termination clauses, again, predominantly for your inpatient hospitals, have an unwind termination clause. If they were to term it, it means you can no longer add employers. And then it still allows every employer that was attached to it to run through their entire plan year. Very important. Submissions of claims follows the same type of logic. Your employers are running on different, right? A cadence, an annual cycle with a run out. And so if you're submitting claims 18 months ago and you're allowing that to happen in the contract, your direct contract, you're going to cause problems at stop loss layers, at individual employer layers. And providers, again, they need to know this. That's what I mean. Open direct contracts understand this. So the submission of the claims becomes timely. 180 days, 90 days? Awesome. And then exclusivity language. These are fiduciary-based, ERISA-based employers. You better be darn careful that you're not writing contracts that bind them to not do some other cost containment strategy. I don't know that's an arena you want to play in. Bind a vendor, bind your direct contract administrator, bind a broker. Don't bind your employers to dictate what they can or can't do with their health plan. So from the provider perspective, why is that important? They're the services you're actually purchasing. It has to work for them long term, or they'll just turn it off. Remember that termination clause? Here's 4 things. We're working with a group. It was 7 hospitals and about 800 providers that wanted to move their services out via a direct contract into the self-funded community. And they'd been trying for a couple years with some success. They had about 6 TPAs that were now representing a few clients that were accessing their direct contract. And these 6 TPAs, so every time a member would come into, right, the provider, they show their ID card. And these 6 TPAs now had all 6 different logos, 6 different payer IDs that the registration office was supposed to ingest and then attach the appropriate things so it cascades through the whole revenue cycle appropriately. And in addition to that, each TPA also represented PPO clients. Some also represented no network clients, RVP clients. And they basically said, it's impossible to identify. Okay, if it's impossible for the provider community to identify, do you think they want these to grow? No. So we have to start recognizing that the dumping ground, like when I came into this, I was like, oh my gosh, bless all of you TPAs. Because when we don't know who to give it to, who do we give it to? The TPA. And now they're supposed to be like cutting edge experts at everything. And we've done the same thing in the direct contracting space. You're like, oh, now you're also supposed to manage an unnetworked network direct contract, and you're supposed to manage everything. It's not going to work that way. You need to look at things at a direct contract administration level, not just at a plan administration level, so it works for the provider community. The second, the CEO of this group that we were working with pulls me aside, he shuts the door, he pulls out 2 claims, and he said, Garrett, these are the exact same claims. The only thing different is date of service and the employer that the members are associated with. Riddle me this, why was the allowed amount different? They're the exact same, coming off the same rate sheet. They're just administered by 2 different TPAs. Why are they different? And I'm like, oh, that's the right question. Do you realize when the provider gives out a direct contract, they don't really know where it's going in the current space? Who's actually administering it? Who's actually repricing it? There's lack of integrity in that domain. And in fact, many that have these contracts, they're not even structured to adequately take the responsibility. It's just been given to them. I said, yeah, that's a problem. We need to rectify it. We need to centralize how these things are being repriced so there's integrity in it. And then third, updating. We think these direct contracts are dead. They're not. They're living. Okay, there's actually providers on the back end. Have you heard of M&A activity? Whether we like it or not, what you sign up on the direct contract and the doctors or the TINs that are represented at 3 months away, 4 months away, 5 months away are different. And if you are not getting those updates, you're not administering the direct contract correctly. And so if it's not easy for the provider to get those updates to you, this provider's like, I've got 6 different TPA sets, 6 different brokers, 6 different, maybe it's with a stop-loss carrier. I've got to get that out. I don't know if they receive it. I don't know how long it takes them to update the cycle. Our claim's going to come through that should have been on the direct contract. And they're like, yeah, grow this, right? And then the fourth is they don't know who's administering it. If a broker gets a direct contract and it's in their name, brokers do not have the operational infrastructure to actually administer that. Many TPAs don't, stop-loss carriers don't, RVP vendors don't. That's not what they are. And so they don't even know whose neck to wring if there's a question. They don't know where to go to make the buck stop. Where does it stop? So we have to know who's administering it. It's got to work for the provider community if this is going to be replicable, if we're going to scale it. The other constituent in the direct contract, your provider, your employer, it's got to work for them. Here's 4 things to consider. Independent. Up until now, again, go to your TPAs and thank them. You've asked them to do something that is not their core competence in many situations because they hold the predominant load. What I love about the space is unbundled self-funded health plans, which means anytime you're rebundling certain things, you better be darn careful. And what we see happening is direct contracts are being rebundled into RVP vendors. Direct contracts are being rebundled into your claims payer, your TPA. Direct contracts are being rebundled into your broker community, which means that it's not unbundled anymore. And from an employer's perspective, the advantage of it being unbundled is if you need to switch your RBP vendor, your TPA, you can still keep all your direct contracts. Because if they're tied to the TPA or tied to the RBP vendor that has another core competence role within your health plan, it's not an independently held direct contract at that point. And that has long-term consequences, not just in that specific example, but every TPA doesn't serve every size employer. So how are you going to serve the micro and small employers when this TPA only serves mid-market? How are you going to serve your enterprise employers that need to come into this when your TPA only serves mid-market? We need to start thinking that you need a direct contract administrator that's core competency is to be independent, hold and administer your direct contracts. Maintenance. Oh, maintenance. It's back to the same thing, but providers have a responsibility to let their members know who's part of the direct contract, which is no easy task because it's always changing. So whose responsibility is it to maintain the roster of providers that are associated with the direct contract, the provider directory? Compliance. Employers assume responsibility of payer. It doesn't magically happen. Compliance indicates some written trail, maybe. That'd be preferable, necessary. If you don't have documented evidence that the employer has joined into this and assumed responsibility of payer, be careful. Because you may be falling out of compliance, which what I mean by that is you may be entering into this network space, which has a whole set of compliance. You've got to have documented evidence that the employer is assuming responsibilities of payer. Claims routing and repricing. One, it needs to be done with integrity. And two, our firm belief in global direct contracts, it's got to fit into the exact same system the providers and the TPAs are currently using, which means payer IDs, clearinghouses, claims coming with an HCP04 indicator and a network indicator to the TPA house with a fully repriced claim ready for plan adjudication. It cannot be a bespoke process, a one-off process every single time, some custom model, some custom way, some custom this, some custom that. No, that's not replicable, that's not scalable. The claims routing and repricing has to start clear from the member ID card with the payer ID, and it's got to connect at clearinghouses, and it's got to have all of the indicators coming through on the claim to your TPA partners so that they can do their job, so that the employer is happy. This all matters. At the end of the day, we're doing this, and what we just went through is so that it can be replicable, so it can be scalable, so that it can start not just impacting one employer, but the entire community. We've done work in the Nashville marketplace, and just February 1st, we had a small brewery, 16 lives. 16 lives anchor their health plan in a direct contract with their local hospital. You know what was cool about this? The executive at the hospital that is over the direct contracting space called the CEO and said, "We're so excited for this relationship." I know behind the scenes what they've said internally is we've never viewed employers as our clients. We've never viewed employers as our clients. And she basically is now saying to this CEO, "We're so excited that you're our client and we intend to take good care of you. If you have questions, let us know." Much of America is small group. And if your direct contracts are designed correctly, they can start impacting not just your enterprise employers, but your small group as well. And if you can impact small groups with that change of relationship, I mean a call literally from the executive over this program from the hospital. That's different. That's what I mean. In replicability, it's got to be a change of relationship. Imagine what you can do with a group that has 200 lives, 700 lives, 20,000 lives. And I don't put those numbers out and say, imagine what you can do to the provider community. Imagine what you can do with them to start impacting your entire community. How these programs grow. I like to think of it in multiples of 3. If you just want 3 employers, if that's all you're looking for, that's your vision, it's just your book of business, we call this the white knuckling phase. Okay? Hold on for dear freaking life. You can do it. It's going to be a wild ride, but you can hold it all together. Okay? Awesome. If you want to get to 9, we call this the I need some processes, but they're all manual. Excel's my best friend phase. And this is where you start running into what we talked about, right? The provider problems, the employer problems, because it's not replicable. You've got identification problems, integrity problems. This is, as an advisor, this is really where Doug got to in his program. It's 9, right? That idea. If you have a vision of 27, 81, 243, where it's actually a community and you're changing your entire community, it's not just for your gain. We railed all the hospital systems, and I come into the broker world, and I'm like, holy God, I went into the wrong employment. Like, what the heck? You make how much? If it's just about your back pocket too, don't even get into this space. Stay at 3, white knuckle. We don't need you. But an infrastructure play is needed at 27 and 81, where we're starting to come together and say, no, we can do this together. We can start to make changes. We can understand the types of direct contracts that are needed in the space. Open direct contracts. We can understand that it's actually in bringing the providers to the community, making sure it works for them, as well as the employer, so that it can finally deliver a sustainable but a great experience for your member, because it can be done and it is being done, where the employer is saving 15, 30, 40% compared to traditional, where you can start finally creating something that can impact your entire community. That's the goal.
I'm small town Idaho, as I shared with you. Right? The idea of being able to impact a 16-man group is exciting. One of the things that wasn't shared in that picture, the gal in the middle holding the beer up, she's actually the owner of the business. And I can remember the day after she had her first interaction with one of the executives from the health system, where she just said, she goes, I can't believe this is real. But it gets a lot better when the broker called us up the day after he did the employee benefit meeting, as he called it. Not open enrollment, but employee benefit meeting. Because the owner had saved so much money by moving into this type of arrangement that she now added vision, dental, short-term disability, and long-term disability as well. All paid. And then as he was going through and sharing this, one of the workers, there was one worker on the plan that had her whole family on there. She came up to the broker afterwards and said this, one of the only reasons that I have this job is because the employer takes such good care of us and our benefits that I've stayed here. But realistically, I really don't make any money. Not only am I getting even this much more benefit, a better health plan as well, this is like adding an entire month paycheck to me. I can't wait to go home and share this with my family. That's different. That's change. This is the U-Powered Conference. Each of you has the power. Quick show of hands. How many in the room know a healthcare executive in your community, a leader, a healthcare leader in your community? Hands down. How many of you that don't would be willing to call one up to have a conversation with them about how you can make a change in your community? I would hope everybody would want to raise their hand in that situation, because it is possible. And at the end of the day, we have all been operating in silos, just like I was, right? I remember white knuckling, and I remember working with my team to start to put processes in place, and yet we still could only get so far with it. And it was when we began to realize that, hey, we have to work with others. We have to be more open. We have to collaborate. Then were we able to start to get to 27 and beyond and start to really impact the community, not just the large employers, but the smaller employers as well. So my challenge to all of you is to begin to think is, how do we work with one another? Even brokers working together, TPAs working together, coming together to strengthen your community for the betterment of somebody else's community as well. So we thank you very much for the time today, and we'd love to open it up for any questions. Yes, sir.
How do you logically get started?
It's a conversation. Everybody, none of us are exempt from the pain of healthcare. And that even includes the CEO, CFO of any health system out there. I will tell you, Garrett, how difficult is it to pick up the phone and have a discussion with one?
Well, let me give you 2 examples. Because so he said, how do you logically get started? And the thought process in there is, again, that the provider community may not be willing to engage. One of my favorite questions is just to say, hey, what's your experience been with the employers in your community? We think there's been zero, and maybe that's the case in some situations, but more frequently than not, there has been. And here's an example. I'll give you two. These are real examples. So, small town, it was in California. We're sitting with the hospital executive. First time meeting him, and we just said, hey, tell us about your experience with the employers. He goes, okay, you know why I want to sit down with you guys today? No, that's why I just asked the question. I didn't say that. He continues. He goes, we have a mining company in my town. They're on a Cigna chassis. The CEO came to me, literally came to me, sat down in my office and said, we're getting slaughtered. We're getting slaughtered. 95% of my employees are here, like right here in your town. Can you do anything to help us? The hospital CEO said, I don't know. Call Cigna. Says, hey, I've looked at this. I've looked at the claims that are coming through. We know this employer. We get all their business. Can I give them a 10% discount off of what my Cigna rates are? Cigna laughed. Said, no, you can't do that. Okay, if you just let that sit on you for a moment. No, you can't do that. And so you're going to hear stories like this. And then the great thing about, again, you have to remember hospital administration, clinicians, the courses we didn't get in school, you know. Guess where I learned cost containment from? Truly. And so when you start, yeah, thanks. That's why I probably kept him like 2 visits too long. Should have discharged him sooner, but
I paid for
it. As soon as you hear the story, now you have the opportunity to say, look, I work with employers that are taking responsibility, that want to work with you differently. And that's where it starts. Notice where it didn't start. The last sheet you always turn to, the rate sheet. That's the last. This is not a negotiation. You're doing it with them. That's the goal. That's what makes this. Did that help? I mean, do you have thoughts from that?
And one thing to remember is their pain with the traditional payers is just as great as ours. We think they have a good relationship. 90% of the time, it's horrible.
What's the lowest hanging fruit in terms of opportunity in your eyes? The type of community, is it the type of environment, feeding hospitals, you know?
Yeah, we tend to think that, yeah. You know, the reality is when you get into the small town rural areas, it's really challenging. If you get into a more robust metropolitan area, lots of competition within the payers, within the providers, all of a sudden you'll find more of this taking place, but then that can start to break down very quickly as well. So there's a bit of a balancing act that takes place, but at the end of the day, I always say you get 2 or 3 willing participants at the table, and that's where the innovation starts and those problems begin to get solved.
So his question is, where's the low-hanging fruit? Everything he said is correct. I'm just going to add one more idea onto it, where the providers want to. And you don't know until you ask. These things, if you're building from like a cold call and kind of, I don't know, having to force it, can take 2 years. You get a provider or an administrator that is innovative and sees the disruption that's happening and says, hey, I want to be on the right side of history, because they are there at all levels of providers. That's where you start. Often, it's at least a 2-hospital town.
2 more quick questions.
Your shoulder's got to be getting tired.
But harder, 2 more quick answers.
There you go.
Based on your experience and case studies, I mean, what are realistic expectations from, setting this up in a group like that, where it's 2-hospital town and most of the employees are there? I mean, what can you realistically save?
Is it fair to say 20 to 30% in RBP? Is that pretty fair? Same thing. That's what we say. You can get to the same financial experience without all of that contention and noise. No more balanced bills, and still have money left over to inject in a high-performance model where the employees want to go there.
Last one right here.
Yeah, so I've dabbled in this a little bit in my consulting days, and specifically in the Northeast, we don't have big hospital systems. We have very, very unique individual hospital networks. And so my question is, breaking into a market like that in the Boston area, I just wanted to know kind of what your success has been and what those conversations have been like. Because typically what I've had happen is we're negotiating, we're at the table with the employer, with the provider, with the CEO of the hospital network. They're at a level where they're accepting payment here, but they want here. And we can't get to a level playing field.
Yeah, I would say Southern California and probably the Northeast, the U.S. are the two most challenging areas. But with that being said, you guys have some advantages that Southern California does not. There's a lot of M&A going on up in that market right now. We also look at it and say from the price of healthcare, it's one of the most egregious markets. And so there's a groundswell of a movement that's taking place up there where advisors are starting to reach out left and right and saying, hey, I've got a relationship here, or I've got a relationship there. And I think instead of thinking in large geographic areas, we have to start narrowing it down and saying, where's the provider, where's the employer, right? And if we start to realize that we're in smaller communities and we start there, we can probably get 80% of it taken care of right out of the gates, and then we chip away at that other 20% until we get it right.
I'm going to just add a quick comment.
Yeah.
This gentleman brings up a good point. I'm not saying this is easy, guys. I'm saying that if we do it right, it's going to be worth it. So sometimes it's like it is a 2-year process. It's your community. You're going to be there for 2 years.
That's good. That's a good ending note.
Fast enough.
Thank you, guys.
Get the hook.
Yep, that's it.
Thank you.